webinar. Welcome. I'm John Ayanian, an advisor to the Center for Global Health Equity and the director of the Institute for Healthcare Policy and Innovation. It's my pleasure to moderate today's webinar, sponsored by the Center for Global Health Equity. On the next slide, we show our panelists for today. And as you know, today's session is about the role of data science in global health equity. We've got a great panel lined up, shown here from multiple schools at the University of Michigan, from who will be sharing their perspectives on data science and the important ways that it can contribute to global health equity and the missions of the center and our global partners. So we will be hearing from each of our panelists for approximately 8 to 10 minutes. And then we will open it up for discussion and questions from you in the audience. We'll be using the Q&A function in Zoom to take your questions, and I'll be moderating and calling on our panel members to respond. And we hope to have a lively discussion and share with you some new developments in the fields of data science here on campus and with our global partners. So with that, by way of introduction, I'd like to invite the first of our 5 panelists to introduce himself, Professor Andries Coetzee, Director of the African Studies Center and from LSA. And each of our panelists will first tell us a little bit about who they are and where they work at the University of Michigan, and any work they've previously done in low and middle income countries, which are a primary focus for our Center for Global Health Equity. And then they'll talk a little bit about some of the current work or training programs that they're involved with, and how they collaborate across campus, and also share with us some barriers and opportunities that have arisen in their work related to data science or training that could support data science in the future. So we'll start with Andries. Welcome.
Thank you, John, for that introduction and for laying out the context in which our conversation is happening so well. So let me start by briefly introducing myself. I'm Andries Coetzee. I'm a professor of linguistics and director of the African Studies Center, which is part of the International Institute here at the University of Michigan. So I'm the only panel member here today who's not in the health sciences. I've been involved with the Center for Global Health Equity from the early stages, thinking about the center, and I'm really happy to be participating in this important work. So a major part of the work that we do at the African Studies Center is to facilitate equitable relationships between Michigan and partner institutions in Africa. And since we are a university and therefore an institution with an educational and training mission, much of what we do at the African Studies Center is focused on creating opportunities for training related to Africa or in Africa for our own staff, faculty, and students, and also for the staff, faculty, and students of our partner institutions on the continent in Africa. So what I would like to briefly do today is to tell you about some of the successful training programs that already exist on our campus and that the ASC is participating in. Some of them are structured in such a way that the initiatives at the Center for Global Health Equity can kind of smoothly and directly be just folded into them, but all of them, I think, also provide examples or models for how new targeted training opportunities specifically for the center could be designed. And since our time is limited, I will very briefly highlight only 2 examples for you. First is the flagship program of the African Studies Center, known as the University of Michigan African Presidential Scholars, or UMAPS program. So through this program, which is currently in its 13th year already, we annually bring around 15 early mid-career scholars, faculty from African universities to Michigan for semester-long research residencies. A core feature of the program is that each one of the fellows in the program is matched with a University of Michigan faculty member with whom they share research interests, and then this person acts as their host on campus, integrates them into the intellectual community and the broader social campus community. The fellows in this program work on many different kinds of projects during their time at Michigan. depending on their career stage and their own goals or needs at that point in their career. Some use it to finish their PhD, some use it to push publications out from their recently completed PhDs. Some use it to acquire specific skills, for instance, in laboratory techniques or data analysis techniques, which they can then adapt and take back home to their home institutions on the continent. So we are very intentionally flexible in how we structure each fellow's times in the program to accommodate their own specific goals for their participation in this program. And therefore, some of them is much more training oriented and others are more research oriented. So while the fellows are on campus, they also participate in a host of professionalization opportunities and training programs available here on campus. And that includes, them working with an academic writing coach, consulting with the Center for Research on Learning and Teaching, or the CRLT, or the Statistical Consultation Services in CSCAR, whatever their own specific needs and goals are, we connect them with a host of these professionalization opportunities available on campus. And it helps them in their own career, in their own research, but it also serves the training purpose of them seeing and learning how these programs are run on our campus. And often they then adapt that and go and replicate it or create something appropriate for their home institution that addresses similar issues. So this program has primarily a focus for creating opportunities for our partners in Africa, but it crucially also creates opportunities, training and learning opportunities for Michigan students and researchers, right? So our students and our postdocs now have an opportunity to share a lab bench with a scholar from Uganda or Liberia or Nigeria for a whole semester. We as professors, as instructors, are tasked to prepare our students to become global citizens, able to engage with the modern world in all of its full complexity and diversity. But I think these kinds of intensive, immersive, shared working experiences, environments that's created through a program like this actually achieves that goal in a much more fundamental way than any writing or reading that we can assign as instructors to our students. Up until now, we've had 162 alumni come through this program, and that also means that we now, as a university, have a network of scholars spanning the African continent, right? This creates opportunities for our people, our students and faculty and staff to do collaborative work with these researchers in Africa. And it also means that there are now people locally on the ground there who can act as mentors and study leaders and trainers for our own students and faculty and staff when they go over to Africa to do work there. So another way in which a kind of a side effect of this is creating training opportunities for our students. A last remark about this program. The focus on faculty at African universities is intentional, right? So through this, we help our partner institutions in building and further strengthening their own institutions. The fellows in the program go back home, they continue teaching there, their students and their faculty and their institutions benefit from the connections they now have with Michigan and with the international research community. We like to think of this as the multiplier effect of this program, right? The University of Michigan invests in one junior scholar, and that investment translates into benefits for countless of our own students and for even more students at the fellow's home institution on the continent. So this is an existing, ongoing, very well-established program with a proven track record. And it's hence a program into which many of the training initiatives at the Center for Global Health Equity can smoothly be folded into. So if you, for instance, write a grant proposal, reach out to us at the African Studies Center. We're happy to work with you to maybe write a UMAP scholar into your grant. If you are interested in recruiting a scholar from Africa to work in your lab, talk to us. It might be very possible that such a position can easily be folded into this existing program, benefiting from the infrastructure that already exists. The second example that I want to very briefly review is of a very different kind, but I think it again shows how capitalizing on already existing opportunities at the university can really pay off. Michigan has been home to the Inter-University Consortium for Political and Social Research, or the ICPSR, since it was founded in 1962. And the ICPSR has run an intensive summer program for most of its existence that focuses on various topics in statistical modeling, data science, and information science. And annually, students and faculty and researchers from more than 350 institutions come to Ann Arbor over the summer for 4 to 8 weeks to participate in this intensive training program. And although participation in this program has always been open to anybody from anywhere in the world, the cost associated with coming to Ann Arbor for 4 to 8 weeks can be prohibitive for many, and especially for scholars from low and middle income countries. One of the few good things of COVID is that it has made it easier to create access to these kinds of programs. So for the first time this past summer in 2020, the ICPSR summer school went completely virtual. And that meant that participation was possible from across the world without having to travel to Ann Arbor, incur costs for international travel, visa applications, or housing. So at the African Studies Center, we seized this opportunity and we partnered with the ICPSR and with the ISR, the Institute for Social Research, to create a reduced rate for scholars from low and middle income countries to participate in this program. And also we're able to fully fund participation for 12 junior scholars from Africa. And the lesson I think to learn here is that there are many existing training programs on our campus. I talked about 2 here today that are relevant to data sciences and health sciences broadly understood. And that the units and the people on our campus who run these programs, they share our core values, right? And they are eager to partner with us to create opportunities, for instance, for participation of scholars from low and middle income countries. If there's one thing that I've learned from my years working with the African Studies Center is that the Michigan community is eager to collaborate, right? To share experience, to partner with each other. So what our job at the African Studies Center really is to bring people together with shared interests, shared values, and then opportunities arise out of that for collaboration, for pooling resources and interests and experience. And that results in more than what people individually could have done. And I think the same thing is true to a large extent of the Center for Global Health Equity, right? So like the African Studies Center, where we cross all 19 schools and colleges of Michigan, the center that we're talking about today is also intentionally designed to cross disciplines, to cross schools and colleges. So it's a place where you can meet other people with whom you share goals and values and collaborate with them on existing training programs. Thank you.
Thank you very much, Andries, for those opening remarks. I think really framing today's session very well. Our next speaker will be Professor Bhramar Mukherjee. She's the John Kalbfleisch Collegiate Professor and Chair of Biostatistics at the School of Public Health, where she's also a Professor of Global Public Health and the Associate Director for Quantitative Data Science at the Rogel Cancer Center. And she will be speaking about some of her data science work in India. Welcome, Bhramar.
Thank you, John. It's a pleasure to talk to you all. I will be sharing a little bit of our work on the pandemic modeling in India, and this is work by many people presented by me. But before that, I want to talk about a little bit of my background and involvement in global health, as well as particularly a specific program that we run at the School of Public Health. The School of Public Health obviously has a very strong and mature footprint in global health under the leadership of Matt Bolton, Laura Rozek, Rick Neitzel. And what we started a few years ago was to really provide rigorous statistical consulting as well as imparting statistical training and education as a band of traveling statisticians to many countries in the world. Here you can see some of our workshops on big data, on setting up disease registry in Indonesia, in Africa, in West China. So we have this effort has been very successful and very rewarding for many of us. And the goal of this program is really to help support global health research. Sometimes, there are investigators who have a global health project who do not have funding to support power calculation, sample size, grant preparation for them, as well as having an outward interaction with our global health partners in order to build capacity in terms of data science, in terms of modern machine learning, in terms of using electronic health records, but also simple things like designing clinical trials, how to understand missing data in different studies, how to conduct panel studies, various ensemble of methods. So this program has been really successful, and it's a win-win situation for the department, for the school, and our international partners. So my own research has global health interests have been mostly in India. So, and the reason is very obvious. In 1996, I made the choice of coming to this country, but my root, I grew up in India, and I have always felt a very strong connection to India. And my first part of my work was to try to do something about empowering women and children in India. And it's very unusual for a biostatistician to start their own study, but in my middle-age crisis, I did. And these are a couple of examples of cohort studies that we have done in a village in the state that I grew up. So this project has been very, very interesting to me personally, and again, very close to my heart. But then when the pandemic started, and I still remember when we started modeling this pandemic, it was March 16th. And I'm going to try to share the excitement of this narrative here, who has been very influential in all our lives. And there we have many Indian scholars in the School of Public Health, as well as people who are interested in India. We got together trying to understand what's going on in India, and also really do a prediction. And this is where being in a strong department pays off. My colleague Peter Song and his students are already working on a model for Wuhan, modeling the data from China. So all of us got together on March 16th and worked tirelessly to adopt that model and come up with some projections for what could happen to India. We were very worried about about our loved ones in India, because for the first time we are really estranged from our country and we could not really go back. And every phone call, every message was really very nerve-wracking. So as a byproduct of 72 hours of not eating and constantly being on Zoom calls and Slack channels, we produced a 30-page report and a Medium article. I have never written a Medium article before, but this was my first time, because this is a very non-traditional, non-peer-reviewed form for dissemination, but we could not really wait for the intellectual product to be released and going through peer review, because time was of essence there. And if you are interested in our work, for all our products, all our preprints so far are available at this single website. Contains all our Shiny apps and all our packages and software products as well, coveind19.org. So we wrote this Medium article over a period of 72 hours, and the article appeared in March 20th. And as you see, that academic research moves at a much slower rate, so a slower pace. So the actual journal paper appeared in June in Harvard Data Science Review Special Edition on COVID-19, which is also a spectacular issue and has many global examples, including India and Africa. So, so India at that point stood at 536 cases and 11 deaths. That was March 19th. And this was our projection. And the reason we were worried about India, that India has a much younger population, but some of the comorbidities that are associated with COVID-19 have been much more prevalent in India. Also has a very fragile healthcare structure, large proportion of uninsured people. So we came up with projections and we said that, yes, look at US, look at Italy. India is right now small number of cases. It's a country of 1.34 billion people, 500 cases, very small number, but we really need to get used to the exponential growth of the models. And so our first predictions came out, and this has been like, it seems so minuscule right now that we said 60,000 cases could happen, and that was large by May. And we are standing at 500, remember? And we also provided like a card carrying by a statistician. We have to provide confidence interval. We do not just give point estimate. We said that it could go up to 900,000, depending on what happens. And so we woke up and we did this completely as an altruistic project. All of us wanted to come together. The students wanted to repurpose their anxiety and their angst for their parents and about the general situation into this public health data science work. But we woke up and the media had picked up our report, and our Medium article was shared many times. All the politicians in India from both camps, the ruling party and the opposition, started sharing this article and saying that something needs to be done. And as we learned that the media has this tendency of picking up numbers, so they obviously picked up our projections and said that the University of Michigan team says that we could have 1.3 million cases, and which is the upper confidence interval, upper prediction interval of our projections. So there's a lot to be learned from that. And then on March 24th came the India's very controversial 21-day national lockdown. And this was really a very critical time because our work was quoted as a critical piece of evidence governing this decision. And as you know, all over the world, there is a complete polarized opinion about lockdowns and non-pharmaceutical intervention measures. In India, we saw an exodus of like migrant workers, which unfolded into a really tragic story that instead of having a static snapshot of the population, the disease actually spread from the western and the northern part of the country to more to the eastern and southern part where the migrant workers started going back. There's also a social process going on. It's not just data science. It is really a social process that you have to think about when you talk about global health. And there is this social galvanization where everybody lit lamp all over the country, as you can see on the right-hand side, for coming together and to get rid of darkness. So since then, our work has really garnered a lot of recognition and attention, leading to about 700 media clips in the last 8 months and covered by all major news outlets, and with a 4 billion reach. So this is unthinkable because, we do all our scholarly work, but a Medium article, just the time of it. But that also leads us to think about that the app has been really our contribution because it has daily projections for India. I'll just like to say, in terms of data science, there are a lot of dangers associated with what we did. Producing a report in 72 hours, which is being quoted as a critical piece of evidence on a policy which is influencing lots and lots of people, and yet this is very politicized. And so this was an article this is my famous experience story from this whole episode, was that on July 20th, one of my friends called me and said, your team's work has been quoted in an op-ed in New York Times. And when I looked at the title of the article, it said how to identify flawed research before it becomes dangerous. So I thought, my job is done and my career is done, but this will remain one of the highest rewards of my life. The two very good data scientists from Stanford and Berkeley, highly regarded, quoted our work as an example of doing nimble work in a rigorous manner, in a principled data science manner. This is all one could hope for in terms of estimating policies. And so there has been a lot of interesting things, in terms of interviews, in terms of publicity, but also really controversial things, because we also talked about India's low rate of testing and what proportion of cases are getting unnoticed. So with that, I think that India finally has turned the corner, and I'm very excited about this project. I'm going to promise wrap up in the next minute or so. Finally, in the late September, the curve has turned corner from 500 cases to 8 million reported cases, the second highest in the world. I have watched these numbers every day. The case fatality rate and the infection fatality rate in India has been low. every day we produce this table for policymakers, and this has been a go-to place for many people, which has all the metrics, different kinds of public health metrics you can think about in terms of fatality, number of cases, our predictions in one page, all of the model, all of the math in one page for India as well as the states. So this is the project of my life. And in closing, I think that we have to think about in public health, this is the how do you talk about interventions in terms of when the context looks like this. This is the largest slum in India, Dharavi. And how can you talk about social distancing, self-isolation? You can just do your best, and you can see the women wearing masks, the healthcare workers going and checking doing temperature checks. Centralized quarantine was really, really successful here. So you have to really adapt all your models to the social context here. And that has been my biggest lesson. So as we think about the Center for Global Health Equity, we have to remember, from my point of view, John, that we are standing in an unprecedented time where there is a quartet where we need the government, the public, the scientists, and the corporations to be in harmony, because there is a silent conductor and a maestro here, the virus, and this is not always playing in harmony, as we know. So how can the Center for Global Health Equity platform help us standing in this particularly momentous time? I think it can have help us form a launchpad network to go after large grants in a nimble way. It can promote rigorous data science for global studies and also reward high-risk, high-gain research that influences policy. Finally, I think that it can bring intellectual harmony and coalescence in global research campus-wide. So with that, I think I'm going to stop. Thank you very much.
Thank you, Bhramar, and for being an important member of our string quartet this afternoon of presenters, and and showing us a path forward of how we can build a university-wide symphony. I do want to remind all colleagues in the audience that if you have any questions for our first two speakers, Andries or Bhramar, feel free to put them in the Q&A box now or later. After we'll open it up for broader discussion and questions after we hear from our next three speakers. But if you have a question related to either of the first two presentations, you can go ahead and bookmark that for us. Our next speaker is Massy Mutumba, who is assistant professor in the Department of Health, Behavior, and Biological Sciences at the School of Nursing. And she will be speaking to us about some of her work, health-related work with adolescents in Uganda. Welcome, Massy.
Thank you for the introduction. So today I'm going to focus my talk or my discussion on my work on substance use among adolescents and young adults in Uganda. I should point out that as I do conduct a broad range of research covering a number of health problems, because I kind of take a holistic approach, which kind of is influenced by my professional leanings. So you always want to look at the individual holistically. So my research, for example, I will look at HIV, but within that, I cover a whole range of topics, not just health-related problems, but also thinking about adolescents and their stage. What do they really need? So focusing on issues around education and financial empowerment. So within the scope of substance abuse, my project really focuses on addressing the challenge of substance abuse in this population. We know from global studies that substance abuse tends to onset during adolescence and escalates as they progress towards adulthood. But we don't have really good data to understand the dynamics of substance abuse in sub-Saharan Africa, especially in high-burden countries where we know that substance abuse is really contributing to this spike of infections that we are seeing among young people. So in Uganda in particular, Uganda is has one of the highest rates of alcohol consumption per capita. And we know that there are high rates of domestic violence, especially targeting young girls, and we see higher rates of HIV infection in this population. We also know that despite the age limits on alcohol purchase, alcohol is very available within the communities because you have community brewing, but you also have this very targeted marketing of alcohol to young people. And then you also have to think about the global context. So we have this global war on drugs that is shifting drug routes to sub-Saharan Africa because there's poor regulation there. But what this means is that the drugs don't just pass through on their way to Europe, but they're also now seeping into the local communities. Of course, if you layer that with the homegrown drugs like marijuana and cat and all other sort of substances, you really have a situation where young people are increasingly turning to drugs. We also know that we have a really large population of young people, but unemployment is high. So you have really the context where it provides for the seats where you can have, young people are not meaningfully engaged, they're very frustrated, so they easily turn to substance abuse, especially when you have the context where there is these are being marketed to them. So my project really seeks to characterize what the patterns are, but most importantly, to who are the most vulnerable groups and what can we really do to address this challenge. So the grant in particular was funded by the African Studies Center. So for anyone who is interested in really, you're looking at initial steps into finding data that can support a larger grant, the seed grants from the African Studies Center are a good solution. So this was a cross-sectional study, very ambitious. We recruited for 3,400 adolescents and young adults between the ages of 12 and 24. So the reason for this broad range was really to kind of understand right from the young age, which risk factors can we really identify that would be amenable to interventions in terms of identifying who would be vulnerable to substance abuse as they progress through adolescence. We recruited young people from a range of contexts because most studies that look at substance abuse focus on schools, but we know that we have young, really large populations of the segments of the population that drop out early. And it's very important to really understand what are the unique characteristics of these populations, what sort of risk factors they face. So we got both the school-based samples and non-school-based samples. And within the schools, we went to secondary schools, we went to universities, we went to vocational schools, because these are different profiles of your adolescents and young people. And we suspect that the factors that may contribute to substance abuse may vary depending on where they are. Then for the out of school, we looked at those who are employed. And again, within those, we targeted different sectors. So are you employed in a formal context? Is it the informal context? We do have a large number of young people who do what we call in Uganda as border. So it's motorcycle or public transport. And these sectors are very prone to accidents. And the few studies that have been done indicate that substance abuse is really one of the contributing factors. So it was really important that we target this group, along with adolescents or young people who live in urban slums. We also included samples of street children, as well as delinquent youth. So it was really a range of samples that we recruited, but so that was the quantitative aspect of the study. Then from a clinical perspective, we went to look within the mental health hospital. We have one mental health hospital in Uganda. And within that, we conducted interviews with young people who have been admitted for substance abuse disorders to really understand their histories and use this data to really influence or to understand the patterns that we are identifying within the quantitative studies that we are doing. So, of course, the scope of this study presents so many challenges, right from the IRB, because, you're dealing with a very vulnerable population and you have to demonstrate that you're thinking critically about the risks and how you're going to mitigate these challenges that you face. But, from that other perspective, being in the US and working with teams that are in Uganda, it sometimes presents a managerial perspective. And for me, what I've really found to be very helpful when you're conducting this sort of data is having a strong team on the ground. My studies are conducted in partnership with several institutions. And with this one, we worked with Aga Khan University. We also had representatives from the mental health institution in Uganda to really provide that sort of administrative background, but also the oversight over the research assistance, because we had a large team going out to collect the data. So my study is just one of several initiatives that is conducted in several low and low middle income countries. And for me, when I think about the Center for Global Equity, I think of really a platform, one that helps us to narrow the bridge, especially between the health sciences and the social sciences. And I'm really glad that this center is somewhat based in the medical school, because there's so many studies, so many people who are doing work on substance abuse, various aspects within the medical sciences. And it would be very helpful that if this center could create a platform where you're bringing together people with different expertise and allowing us to be able to conduct, for example, multinational studies, drawing on the expertise and resources that we have here at the University of Michigan to really try and mitigate what we see as the global inequities in substance abuse, because it's not just a problem for Uganda, but it's a problem for several other low and middle income countries. So that is what I wanted to share for now.
Thank you, Massy, for your presentation and summary of the important work you're doing in Uganda. Next, we'll hear from Dr. Gifty Kwakye, who is an assistant professor of surgery at the medical school, and she'll be talking about the intersection of mobile technology and data science in the field of global health equity. Gifty, welcome.
Thank you so much. Thank you for inviting me to be part of this panel, and good afternoon, good evening, everyone. So my name is Gifty Kwakye. I'm actually starting my third year in the division of colorectal surgery here at Michigan. And similar to Dr. Mukherjee, I hope I'm pronouncing your name right.
Better than anyone else.
Okay, good, awesome. My story starts as an immigrant to the US. So I was born and raised in Ghana, and I came to the US about 20 years ago, seeking an opportunity to pursue a dream of being a doctor. As a female growing up in Ghana then, it was impossible to do so. So I left searching for that. But I have to say that when I left Ghana, I made a promise to myself that my goal was to come back there and to work and be part of the solution. And that's what's driven me and continues to form who I am, and similar to the panelists, most of the panelists here today. So in February this year, I had the opportunity to travel back to Ghana with Dr. Raghavendran to visit Komfo-Anokye Teaching Hospital. This is located in Massy, within the Ashanti region of Ghana. The medical director at Komfo-Anokye had reached out to Michigan seeking help creating some surgical specialties. So they were seeing increasing rates of different conditions, and they didn't feel like they had the necessary training to meet that. I was uniquely positioned in order to respond to that. And it was amazing. It was the first time that I had set foot in my home country after going through 20 years of training. And I can't express to you how meaningful it was to me. I have to say that it was also humbling, and I ended up feeling very helpless, because despite all my training, all this knowledge I had gained, I was suddenly in this space and I couldn't do anything. And that's because the need was immense. For instance, when it came to my specialty, colorectal cancer, the data out of West Africa, we don't really have a lot of great data from Ghana, but the data from West Africa has suggested that 60% of patients were presenting with stage 4 disease. 5-year survival for stage 4 colorectal cancer in West Africa is 0%. Most of the patients who are showing up, the average age is in the 30s, so people within their 30s to 40s. Even though Ghana's Cancer Department or Center, Ministry of Health, has clear guidelines on screening, none of the physicians we interacted with, and we ended up surveying about 140 physicians at Komfo-Anokye Hospital, and none of them were aware that there were any existing guidelines. None of the physicians older than 50 years, which is the set age at which here in the US we recommend screening, had undergone colorectal cancer screening themselves. And none of them had actually recommended colorectal cancer screening to any of their patients. Komfo-Anokye Hospital is the second largest teaching hospital in Ghana, and takes care of patients from about 10 out of the 16 regions, including neighboring countries, Cote d'Ivoire and Burkina Faso. So you have the best physicians supplying care, providing care to a large population of Ghana, and they were not even aware that, what the guidelines were and how they could get ahead of the diseases that they were seeing. So the Ghana Ministry of Health recommends doing screening with fecal cord blood testing, which is something that we do here in the US in some of our more rural and remote areas. And if you have a positive fecal cord blood test and you go on to have colonoscopy. Now, Ghana has 11 gastroenterologists for a population of 30 million. The GI department at Komfo Anokye had only one functioning colonoscope. They had 2 upper GI EGDs that were working, but they had run out of the supplies, the other gadgets that you need, like a snare and other things for doing your procedures. When we went there, they had like a clothing line on which they were drying out some of the equipment that they had sterilized in the same room where they were performing the procedures. Now, if a patient managed to overcome all the usual barriers and get themselves to Komfo Anokye Hospital because they were having symptoms and needed to be scoped, and the colonoscope was available, the patient had to bring their own prep. They bought their own prep. They would have to bring their own sedation. It's like if I asked you to bring propofol to your appointment or Versed or fentanyl, you'd have to buy this from outside and bring it out with you. And everything that was done during the procedure, you'd pay for it. The GI physician there said, sometimes they've had patients who can only pay for a diagnostic exam. So they put in the scope, they get in, if they see something, because the patient hasn't paid for a biopsy or removing a polyp, they will take out the scope and wake the patient up, let them know what they found, and the patient has to then go find the money to come back and then have a repeat procedure done. And you can see how just being in this setting and then being exposed to all that we have here at Michigan and the things that I get to do each day for my patients. And then being there in Ghana, and I'm a colorectal surgeon, but faced with all this overwhelming stuff, how helpless I felt. I feel like 20 years of training never prepared me for that. So I came back to Michigan, and I was pretty set on trying to convince people here. I mean, this is Michigan. We have to care about this stuff. We're going to find the money, and we're going to go down, and we're going to save the world. We're going to save Ghana. And then I got here, and then COVID hit, and the world changed, and no one had money. The money had dried up. And I feel this need. People are suffering here, and people are suffering there. And I was just so worried about how COVID was going to impact a system that was already broken to begin with. The good thing that happened during that downtime was that it gave me an opportunity to think and to embark on several informational meetings at the suggestion of my mentor, Dr. Agavendran. So it transformed me. I'm on the clinical pathway. I'm not a researcher. If you've talked to me, you realize pretty quickly that I don't understand the ins and outs of doing research. But I was faced with this issue. Colorectal cancer is killing people in Ghana, in West African countries. COVID superimposed on that. And what can we do? How do we find funds? And the idea came up to pursue NIH funds. But as I said, I'm not a researcher. I had no idea about what goes into writing a grant to begin with. And then how do you write a grant to address such a huge problem? It was during this process that I got to talk to Dr. John Pierre. He is a professor of global public health and internal medicine here at Michigan. And he's developed a series of mobile health platforms that he uses to address, help patients and providers manage chronic diseases in low resource settings. Most of his work is in Latin America. And at the time we talked, he was in the process of doing classroom teaching using WhatsApp to try and help providers in different countries in Latin America combat some of the issues that they were seeing with COVID. And it blew my mind. I mean, I use WhatsApp all the time. That's the way I communicate with my family in Ghana. But the idea of using that platform to teach for capacity building, it was like, how do you do this? It became the core idea behind the intervention I subsequently developed for my grant. And then it was coming up with, how do you come up with a team to help someone who has the clinical knowledge, but not the research expertise? And the only way I can describe how this happened is similar to what goes on in Ghana. And I'm going to use my Ghanaian accent here. So for instance, you go meet a friend, you go to someone's house and you're like, oh, Charlie, what are you working on right now? Sorry, the accent is not coming out. But you're like, oh, what are you working on right now? And you're like, oh, I'm doing something. They're like, I know someone. Let me call you my friend and tell you about this friend of mine. And then immediately they'll put you in touch with someone. And that's the exact process that happened here at Michigan. It was, I would meet with one person, I would have a discussion, and they'll say, I might not be able to answer or address a specific thing, but let me put you in touch with this person. And through that process, I found my team. So in addition to a lot of folks within Michigan medicine, like Dr. Akbar Waljee, who's the panelist too, and my collaborators in Ghana, I found Dr. Cheryl Moyer, who's an associate professor in the Department of Learning Health Sciences, and had done a lot of work in Ghana, also around some of the things I was planning on using. I met Dr. Phil Boonstra, who is an associate professor in the Department of Biostatistics. And then there was Dr. Mary Burns, and she's a qualitative sociologist at the Center of Healthcare Outcomes and Policy. And together we designed Conquering Cancer. So Conquering Cancer, actually it's Conquering Colorectal Cancer, is a mobile health platform that puts screening technology and data collection technology into the hands of community health workers. So they go out into the villages, they do colorectal cancer screening with fecal occult blood tests. They put all of that information to a Qualtrics platform, including past medical history, family history, all the other health information. And that platform serves as a makeshift electronic health record. And they sort of communicate and distribute the platform through WhatsApp. And then using WhatsApp, physicians are able to do remote phone or video consultation with patients if needed. The other thing which is included in it is that we use mobile phone addresses as a digital tracking system so that you can follow someone longitudinally to say, okay, you need to have your repeat screening test done, but we don't know where you are. You're not at a physical address or where we last met you, but you'll be able to track people down. And then we are also collecting data on social determinants of health. The goal was to use the platform to then create a risk prediction tool to see who was at higher risk of getting colorectal cancer. Because I didn't think the systems that we had in the US necessarily translated to low resource settings. And this is where Dr. Boonstra has been very, very helpful, helping us think about the science behind that. So that's all to say that it takes a village, and certainly that has been true in this process. And I have to, before I end, just say the coolest part is that since I remember a few months ago, we had an informational session for the Center for Global Health and Equity. And I had the privilege of meeting Dr. Laura Rosek. And so she's an associate professor of environmental health sciences and global health. She's got a lot of titles. Laura is just pretty cool. And it turns out that Laura and her team is studying colorectal cancer tumor genes and trying to find if there's a connection between social demographic factors and how aggressive your colorectal cancer is in African American populations. Her team is doing work in Ethiopia, in Ghana, in New Orleans, in Detroit here. And even though she has impressive people on her team, she didn't have a colorectal surgeon. And so I'm sitting in this meeting, and now it's almost like I fit into this puzzle. I find another way that I can do something meaningful. And it was thanks to the opportunity that CGHE provided. So this year has taught me a lot. It's taught me some pretty hard lessons. But the one thing I've come to appreciate is the fact that it opened my eyes to realize that there is more to Michigan than just Michigan medicine. There are amazing people in all our different institutes who are so eager to collaborate and to help. And it's restored my faith in our ability to do some good, not only here, but in the world. So thank you.
Thank you, Gifty. And I think from each of our speakers, I'm so impressed by the passion and commitment that you're bringing to your work. And that comes through as you tell your stories, and the stories, Gifty, that you tell of making connections across campus, I think are very instructive, especially for faculty earlier in their careers that may not be fully settled on their research or scholarly path, and aren't developing it, and it's a work in progress. Being able to make the kinds of connections you describe, and to the extent that the Center for Global Health Equity can help you and others make those connections, I think is a great model for increasing the impact and the quality of the work that we're all doing and so passionate about. So I think we'll hear that same passion and commitment from our fifth and final speaker on the panel, Dr. Akbar Waljee. He's an associate professor of internal medicine in the Division of Gastroenterology at the Med School. He's also the associate director of the IHPI Data and Methods Hub. And he will be talking to us about some exciting opportunities that he's helping to lead and jumpstart in responding to major new initiatives of funding from the NIH for data science in Africa. So welcome, Akbar.
Thank you so much, John. And Gifty, you sent chills down my spine, primarily because the passion and the excitement that you energized through your talk is clearly obvious. A little bit of background on me: I was born in Kenya, similar to Gifty. Got sent here to train with the hope that I would eventually come back to Kenya to participate. And it's been, wow, more than 11 years on faculty. And this is a point in my life where I reached out to Dr. Kollars, a mentor to me, a friend, and said, I really want to feel like I'm having impact. And can I find some like-minded people that are just as energized about contributing to the world in the way that that could be meaningful? And the excitement here, for me at least, is that beyond this seminar, which is trying to highlight some of the work that we've done, we're really trying to find these like-minded people, this quartet, this group, to identify a community of practice, a group of people that Joe likes to call, Dr. Kollars likes to call, of investigators, of staff, of faculty, that we can bring together in a way that when opportunities arise, whether it's a grant, whether it's a collaboration, that we're not having Gifty, for example, spending 7 months trying to identify the right colleagues to execute on something that's important, that is non-transactional. Clearly, this passion and dedication that Dr. Mukherjee, as the chair of a biostats department, is gravitating to an important, sort of pandemic in India that's taking the lives of people that are our family, our friends. And how can we use this platform and the Center for Global Health and Equity to find these matchmaking that's much more easily to develop at the University of Michigan, where there's so many amazing people. I just got to meet Andries for the first time a few months ago, and I can't imagine that I haven't met him before, and how much I've learned from him, especially in the context of getting funding from the African Studies Center. But what I'd like to talk to you about is an opportunity that got launched recently by the NIH and Fogarty around harnessing data science for health disparities and health discovery and innovation in Africa. This was launched at the end of July, and it's a $53 million mechanism around 4 real big thematic domains. And I'd like to walk you through it primarily as a potential opportunity, but also to show you how we as a community across the university came together to say we can do this. So this 53 million initiative got launched in July. The application is actually due in December. But the first sort of project / grant mechanism is around a research hub. This research hub is a U54. 5 awards are going to be awarded in this domain, roughly about 1.3 million a year. And the hope is to engage with an African PI. So an African PI has to be driving this initiative with the help of potential colleagues around the world. So our partner in this domain is the Aga Khan University. Massy had mentioned being engaged with them. I actually didn't know that, and is excited to hear that we have a mutual collaborator. The Aga Khan University has health systems and university across Kenya, Uganda, Tanzania, and of course in Pakistan and in Tajikistan. And as a partner, they were interested in 2 domains. They don't have a very significant data science or a data science initiative, but they had 2 particular domains of interest in health-related topics around maternal and child health and around suicide and depression, something that is not taken, is not up on the list, primarily because we've been dealing with communicable diseases for a long time. And so, it was easy to gravitate to people around Michigan as well as locally to help engage in those two health domains. But really what's needed in this grant is the data science component, right? And this is where our strengths lie, right? So we've been engaging with biostatistics, obviously public health, to LSA in the statistics department, to bioinformatics, to develop our data science core that will allow us to execute and help our colleagues in Africa to achieve success and more importantly, impact, right? We want to be able to develop strategies to have direct impact to the work that we're doing. And I feel like data science is clearly emerging as a priority. I don't think there's been a time that people have looked at more logarithmic charts than now. Every data to have impact, right? And this is the time to leverage that and take advantage of that. So not only are we helping them in that domain, but we're also leveraging, the school of the business school, Dr. Paul Clyde, who I think is on the call too, to help us think about ways to disseminate this information and to have sustainability. What are the opportunities that once this grant is done, that it continues to propagate in a way that will be meaningful? Because traditionally, at least in our academic careers, we get that one grant, and after 5 years, we're done. Then what? We move to the next grant. But here, there's an opportunity to keep sustainability and think outside the box. And we have such amazing resources across the campus that I feel we haven't been leveraging. And now the Center of Global Health Equity can play that role of helping us integrate across everybody. And that's what really excites me, to find this community of practice that we can engage with. And to be honest, that's why I'm in academics. This is the highlight of my day. This meeting, this conversation today is the highlight of my day. The second initiative around the DSI Africa grant is a research training program, even a better opportunity. And we have Dr. Boonstra in biostatistics and public health, with Dr. Moyer leading this initiative, with in Ethiopia, the Addis Ababa University. And we're developing a training program around data science to help foster, fact locally to be able to apply for grants around data science and to utilize those humongous data sets that they have right now. I think one of our colleagues in Addis Ababa mentioned that we have all this stuff and we've had it for 20 years. We just haven't used it to and leveraged it in a way to have impact. And so, for this call, or this proposal in particular, they request that we have mentors and faculty across bioinformatics, statistics, mathematics, as potential ways to provide support, even as just faculty. And I can't tell you how much response we've received. And again, if you feel anybody on this seminar feel that they would like to contribute in that way, please reach out to us, because we're looking for faculty mentors who, we've received about 20, bio sketches, knowing that there's no transaction here. There may not even be any effort here, but that you are part of something that could be really impactful. And so we're really excited about applying for that project. That's a $350,000 a year mechanism over 5 years. 4 awards are going to be awarded in that domain. And again, something that I feel privileged to be part of the University of Michigan just to see that launch. The third initiative is around the ethical, legal, and social implications of data and the data use, data privacy. This is something that's extremely important as more and more data being collected through mobile apps or through other mechanisms. So this mechanism is a UO. 4 awards are in that domain, $400,000 a year. And here, we've had some amazing people. We have Dr. DeVries, who's part of the Center of Bioethics and Social Science, Cheryl Moyer, who's helping lead that too. And we're looking to identify partners in South Africa and possibly Kenya and Cameroon. It's been tricky because unfortunately Cameroon, as you may have heard, have gone through a crisis lately where there was a shooting of young children that's impacted the population there. So everybody's clearly struggling, but clearly have a motivation and excitement to work together to improve the health of those local populations in low and middle income countries. This was facilitated by ISR, the Institute of Social Research, again, an entity on campus that has been working in this domain around survey instrumentation and the health and retirement study that I feel we're just not capitalizing as much as we could. But now with the Center of Global Health and Equity, we could provide these matchmaking strategies that allow us to be prepared so that when these grants emerge, we're ready and prepared to tackle them head on. The last initiative, which I won't talk too much about, or within that $53 million DSI Africa, is a coordinating center, which is only one will be funded. It's a $2.2 million project a year. We'll develop the infrastructure to share data across all the awarded sites. Again, to capitalize on all the awardees, to emphasize the importance of data sharing, which I think is very strategic on the NIH's part, especially because we lack so much data from the African continent. But anyway, I'm going to stop because I can obviously be enthusiastic enough to talk all day, but I hope this provided you some context as why we think this is really important.
So thank you, Akbar, and all 5 of our speakers. I want to remind our colleagues in the audience that we welcome your questions in the Q&A box at the bottom of the Zoom screen. We have one waiting for us, and I have several other questions that I have prompted by the remarks of our panelists. But let's start with the question from the director of the Center for Global Health Equity, Dr. Joe Kolars, who asks for Professor Mukherjee, your nimbleness in response to the pandemic in India is impressive. How were you able to fund and support the work in such a timely way?
That's a great question. So in the beginning, of course, we didn't have any funding, right? So March 16th, and we are used to COVID-19, but being part of a privilege of tenure is that you can choose. It's very hard to get fired, right? So I think that I basically donated my time in pro bono, but quickly what happened was that there was a grant opportunity by Midas. And we wrote our grant in terms of just devising testing strategies, optimal testing strategies, the initial modeling being done. And then one thing which really helped us in terms of resources, we are all contributing our time to do something which is meaningful for us. And at the time, I think we forgot everything else, what else can be relevant. And that has been the story for the last 8 months, that it is very hard to focus on anything else until we sort of see the end of this. But I think one thing which is in terms of resources was very helpful is that I reached out to Ravi Pense, because all of these models, the 20 models for India, all the Indian states, and to run the Markov chain Monte Carlo, it takes an incredible amount of compute power as well as time. So we actually got lots of computing support as partnership from Michigan, which really enabled over the last 8 months running these models daily. And that's exactly why it was not just an academic work where you write your paper and forget about it. 6 months later, the revision comes back. It's not that kind of work. So it really taught us a lot on how to do it. Now, we are responding to a lot of the opportunities because now we have this paper, and we also have worked quite a bit on the Michigan electronic health record data. Now we have preliminary record to go for the funding. But I think we just dove into it just like, without thinking about it. Was much more altruistic than thinking at that time. I don't think we were thinking any pragmatic decisions, but then it came. So yeah, I'm very grateful for the support from Midas as well as the support from the University of Michigan Advanced Research Computing.
Staying on the topic of funding for a moment, Andries, you had, I think, mentioned briefly seed funding from the African Studies Center, Gifty. I think you may have mentioned sort of the learning about that as well. And Massy, I don't know if you've received seed funding for any of your work within the university, but I wonder if others on the panel would like to comment on some of these resources that are available that colleagues in the audience may not yet be aware of.
Yes, so the African Studies Center regularly funds projects at an early stage, right? We don't have the kinds of funding like the grants that Akbar was talking about, but we have sufficient funding to support research often in that early exploratory phase. enable people to get the data they need to then submit the bigger grant proposals. So certainly any of the topics being discussed here today would have been competitive and asking for at least initial seed funding from the African Studies Center. And we are tasked by the university to do exactly that. And we get funding to do exactly that, to lower the barriers of entry into the kind of work that we're being talked about here today. So, I mean, whatever your work is, reach out to the African Studies Center, but reach out widely. These opportunities are available across this campus, as we've heard from every presenter here today, right? And that's why we need places like the Center for Global Health Equity or the African Studies Center that is tasked with collecting information from across campus to make it possible for people to find the funding opportunities and the collaboration opportunities.
You, Gifty or Massy, anything you would add to those thoughts or sort of paths you're pursuing to fund your work internally or externally?
So the Department of Surgery has some internal funding sources for early career faculty. The difficulty has been due to COVID and the economic response. A lot of that money has been frozen, so which makes it very hard to then continue some of this work. A lot of what I've done so far has been using my discretionary funds. That was part of my package when I came on, but as it can only go so far, and that's what makes it a little bit difficult. I think, again, part of my problem was that I was so focused on my little silo here within Michigan, within my department, and was very unaware of all these opportunities. Like, it made my day when I met Andries, because I was like, wow, and it's the African Studies Department. I should know about the African, that's like home, that's my people, but they didn't even know about it. And even the funding that's there, which aligns completely with the work that I'm passionate about doing. And so I think it requires a little bit more thinking outside the box and looking outside of our usual silos.
So another question we have from Dr. Jim Williscroft, who's joining today's webinar. Akbar, you had mentioned the importance of thinking about the ethical use and quote unquote ownership of data. How do you and others on the panel address this issue in your own work? Obviously a seminar on data science, data is what fuels the work, but we have to think about, like any other resource that we might share or develop with global partners, how do we do that ethically?
That's a great question. By no means am I an expert in this, but clearly, with the use of more mobile applications, and technology, and smart devices, this is important. But it's not only that we have to think about these for the betterment of the individuals that we're taking data or using data from, but there's also local country governance that's important to reflect on that could vary from country to country. For example, it's very clear that Kenya will not be allowed to share data on their local citizens independent of any collaboration that you're having, primarily because Kenyan citizen data needs to remain in Kenya. Even the option of using that on a cloud, at least as of right now, which makes it terribly challenging when you're trying to do work across different countries and across different platforms. And so these are things that are just evolving. They're clearly things that we're evolving through here. There are different approaches that we've been thinking about to navigate through these, some of which including encrypting and de-identifying of data, other ways of developing a federated model of data where models are built within the individual institutions and then are more centralized to create a more generalized model, developing a model in one place and validating it on another. These are all, developing synthetic data sets. These are all things that we're having to think about in order to make sure that we protect the data of our citizens. Bhramar, I wonder if you had any other thoughts on that.
Yes, thank you for that great question. So I think that there are a couple of things in the global health setting. I think that you have to really think about that, the where does the data reside and what are the different IRBs and the institutional protocols, because it's quite different in India. My main experience is in India versus the United States. So in India, many times, they will send you this whole spreadsheet, because there is not a very, in many institutions, there is not a very strong IRB structure with all of the information. So you have to really set up the protocol well in advance, that what is shareable, what is de-identified. And I think that there is a lot of research, if you think about United States, where we are doing a lot of work on electronic health record data, genomics. It's very easy to identify people when you have so many geocoded residential information data. It's very easy to identify people. So we have to really think about the differential privacy domain in a very careful way. And as Akbar mentioned, that there are many ways of masking the data, but in Michigan, we work through a honest broker system where encrypted IDs are what you get. And there are certain views of the data which are allowed, so that we cannot merge everything to identify a person. So I think that you are absolutely right. In particularly LMIC such a situation, these restrictions are much relaxed in a sense, but I think we have to be vigilant. We have to maintain the same standard of reproducibility and scientific rigor. And that's one of the things which was very rewarding for me, because people always say that data from India, we don't trust them, like, it's garbage. But when you do the highest quality of data science, you still have to put forward the best tools, even if the data is imperfect. And so when you get quoted for your modeling in India in a New York Times op-ed article by two leading computational biologists, then I feel like we did the somewhat of a right data science, even if there are gaps in the data, gaps in testing, gaps in the resources. We have to maintain the same standards.
So we have a question from our audience for Massy. Roy Clark notes that he was very impressed by a program at Mbarara University that he learned about through you that involves student community outreach in Uganda. And he asked, can you comment on the impact that program has had in gathering data on the needs of disadvantaged communities?
Thank you, Roy. So just to give a little bit of a background on this program. So as part of the community health training at the Mbarara University in Uganda, where I actually did my undergraduate studies, students go out to different communities in teams. These are interdisciplinary teams. So you have the medical students, the nursing students, medical lab, and increasingly they're integrating the humanities students within these teams to really provide a complex, a whole range of views in terms of addressing community health problems. And in the context of engaging communities, students gather a range of data from these communities. So they do household surveys, they meet with community leaders. So you have a really wide mix of data. And because this program has been running for over 30 years, you have repeat data collections that are happening. So these programs are important in the sense that they really highlight what the needs are within these communities, but also how they're evolving and how student teams may be impacting the health problems that they seek to address, which vary with each year, depending on what the team's identity needs. But I see this, I think what is really lacking and could be an opportunity when we begin to think about data science is how can we use tools, for example, like simple data collection tools that could allow this data to be merged, especially with clinical data, to provide a much more comprehensive view of what is really happening within these communities, not just in terms of the public health data that are being collected on social determinants of health, but also how do these really inform what we see from a clinical perspective to guide the decision-making or the policy that needs to happen. I think on my part, this model has been very helpful in my approach to doing work in communities, and I do really utilize quite a lot of community-based programs. In my work with Aga Khan, we do have students that work and help us collect data on household surveys. In this case, we focus a lot more on NCDs, especially hypertensive and heart diseases, because that's really a critical need right now. But I think such models would be very helpful where you don't have regular data collection on communities, but you can use students as models to really go in and collect data.
Massy, I want to ask a follow-up question going back to the earlier issue around the ethical use of data, and you described discussing some fairly sensitive topics, substance abuse and likely mental health issues that go with substance use in adolescents and young adults. And sort of have there been challenges with that? And how do you, for example, interact with IRBs here at the University of Michigan or in the communities where you're working in Uganda to ensure that the data are protected and and handled in a way that generates important research knowledge, but does not jeopardize the privacy or the security of the people in the communities you're studying?
Thank you for that question. So I think Uganda is in the sense that you have a long history of conducting research, mostly HIV/AIDS research, that has helped set up a lot of infrastructure, especially around local IRBs that oversee research. I think there's a bit of tension sometimes between what the IRB in Uganda expects and what Michigan expects, especially around what is considered sensitive information or what is considered a sensitive topic. Because in Uganda, I can usually ask someone about their HIV status, whereas in Michigan, that's a big no. And sometimes that data is important in really being able to identify what the needs are. But I think we really navigate that space going back and forth between the IRBs until we come to a compromise that works for both. Most often, Michigan is more stringent than the local IRBs in terms of limits are. But we also worry, especially when you're conducting a study around substance abuse, because that's an illegal behavior. And the protections that the US offers to researchers do not necessarily apply to the Ugandan context, so the police can potentially seize that data. So for this particular study, it was important that data, we didn't collect any personal identifiers. And when we are going into the communities, we do quite a lot of outreach, reaching out to, we have village council leaders, and being able to engage with them to make sure that they understand what this research is for is very helpful, because then they offer some level of protection if you have, for example, if you have the police coming in and trying to interfere with the research activities. But on the issue of ownership of data, I think that is really important. And one way we address that is really making sure that local researchers are also included in the teams and have the opportunity to publish on this data. I think for me, that is really important, because I've been in studies where you conduct research and all the data is sent back to other countries, and local researchers who are actively collecting this data are not able to really appreciate what is coming out of this data, because especially if we publish them in journals that are not available, because again, we have to think about the global inequity in access to information. That these we publish in journals, often they're not open resource and require subscriptions, and people that really we collect this data from do not benefit from those data. So those are things that we think about critically, and also trying to publish in open resource journals.
Thank you. Any thoughts from any other panelists on this issue of working with global collaborators and the data sharing approaches that you take?
In the projects that we designed for the colorectal cancer screening in Ghana, the way it's set up, and I love that the NIH sponsor required this, is that the local collaborator has to be on the same level as a co-principal investigator or co-investigator, and that they had ownership of the project. It was important to us that we found something that was a priority to our local partners. And the way it is designed, the local partners are the ones who are actually getting all the data. It is because it's going through Qualtrics, well, we are simultaneously getting access to it. And they are the ones who are deciding how to use it, because it's primarily for clinical. My main hope is that it'll be used for a clinical agenda with a research one superimposed on it. And so it is built into it that they have that ownership and the right to the data, because it's their people that they're taking care of.
Bhramar, anything you would add from your experience, particularly in the COVID-19 project in India? You shared with us an image of the team that you're working with. Are some of your collaborators in India, and sort of, how do you manage that collaboration?
Yeah, so thank you for that question. And there are, of course, there is a lot of people in economics and social. So India has a very poor structure of public health because there is no established school of public health. There is not a very strong legacy of epidemiology and biostatistics. So they are really looking for collaboration and partnership. Many people are. And in the most of the research have come out of engineering, economics, and social science in India. So those are our colleagues who are our partners. But the government has been really proprietary about the data. For example, seroprevalence data, it has been really hard to get those data. Even I think that in general, Indian official statistics is a very data poor environment. And so it has been very hard to quantify what is the excess death and mortality, for example, because you can compare that. And it's very easy to do in Western developed countries where you have a good archive of data. But I think that has sort of raised the awareness of Indian scientists and the government that they have launched an universal like data science program where everybody is going to have ID and connect all the electronic health records so that they are more prepared. So Modi actually announced this in about 1 month ago that there is going to be an initiative because there has been so much issues in terms of data linkage, death records, and assigning cause of death, everything that we see in a smaller version here, very widespread in India. So it has been a challenge, but you can do a lot with the web scraping and the crowdsourced data sets that you find. That's sort of modern data science. There is a new generation of techies who are gathering all of these data and putting them there. So you have to know that how to really harness that information.
And Andres, just to finish on this topic, I wonder if there are examples that you've seen through the UMAPS program or other training efforts that the African Studies Center has supported, where it's led to ongoing sort of data collaboration in some of the ways that we've heard about in this session today. We've heard about the Data Science in Africa training program that Phil Boonstra, the proposals, he's leading a team of about 20 faculty. And, as we sort of train and build human capital and, human resources, are there ways that we can think creatively about partnering with people we're helping to train, both at the University of Michigan and through our global partners, that might overcome some of these data hurdles that are common in all fields of health research, but especially working in low and middle income countries?
So specifically out of the UMAPS program, I mentioned we have 162 alumni in the program, and many of them, though not all, continue to collaborate with their Michigan partner for years or decades after they spend their semester year on campus. And some of those projects are in the humanities and might not involve huge data sets, but there's just as many in the health and public health and quantitative social sciences domain. And they often do involve ongoing collection of data and large sets of data. One of the things that I think, and I think Akbar mentioned it also, one of the things that's true in a place like Africa, and I'm sure more generally in low and middle income countries, is often the problem isn't the creation of data sets. Often the data sets exist, right? The governments have been collecting them. The International Monetary Fund or the World Bank or the World Health Organization have been developing these data sets. The problem is the staffing, the skill to analyze those data sets is often not present. So that's why I think it's really important to focus on how do we contribute to the capacity? How do we take the capacity that is there and ramp it up?
Thank you. So another question that we have in our Q&A box from Dr. Joe Kolars is, what are some novel data repositories? And I think this follows on your last comment, Andries, but each of our panelists may have thoughts. What are some novel data repositories that could be particularly informative for global health in low and middle income countries, in any of the countries that you all are working in, that you've discussed in your comments in this panel? Any thoughts from any of our speakers?
I think I mentioned this a little bit before, but mobile application data, sort of new innovative ways to leverage data in the local African population. A lot of the, obviously the mean age is much younger. There's a huge access to all mobile technology there, and in some ways it's fairly advanced in terms of their mobile technology. The use of social media data, that has its own caveats related to the biased population. But the Midas has a sort of a 10% sample of tweets that go out daily. In fact, some of the biggest African countries where we get millions of sort of tweets on a daily basis are some of the countries are Ethiopia, Nigeria, Kenya, South Africa. And it's interesting to see the data that's emerging even during COVID. After potentially a politician or a famous person dies in an African country, you get these messaging around increased hand washing, hygiene, masks, and it's interesting to navigate through that data. Again, it doesn't give you answers to everything, but it's a messaging system that gives you sort of this new kind of data, a more live stream of data, almost like ICU data, where you're getting continuous information, and leveraging that data in innovative ways is something that excites me. I'm not sure I have the answer on how to do that, but those are some of the potential approaches to leveraging new kinds of data.
Yeah, so I think Joe is also trying to ask, like, repositories, existing repositories, not just what kind of domain of new data collection. So I think something like a global health data exchange, but focused on LMIC countries and this new domain of data, I think will be, and a sort of IHME focused on low and middle income countries, or like having more deeper dive into the country focused way. That will be great to have. But also, my project in West Bengal, my first project in the villages showed me that what we did was to train women in the villages to learn how to use iPads and collect, like, community health workers to keeping track of the health of mothers and children. And basically what we did, that as soon as they collected that data, created an automated server in Michigan, which ran a very simple decision tree model saying that if your hemoglobin is below this, and if you have protein in your urine, this is what you should do. And those messages actually automated way went back to the text phone. They don't have smartphone, but most of them have mobile phones, went back to the text message to the community health worker and the woman. So this was just like a very simple in terms of data science, but highly, highly impactful. And so, and you can train the community health workers with sometimes when I do data science research, I feel it's so esoteric, so decoupled from the country that I grew up in. But these tools can show us that telemedicine and to teaching, empowering women with data science, it can change the landscape, the health landscape of villages in this country. So I am really interested in that penetration of these advanced methods into a very underprivileged communities. I'm really interested in that.
Can I quickly jump in? So the asking about existing data repositories, I mentioned the ICPSR earlier, and just now I jumped on their website. They are primarily a repository for large data set, an international consortium that collects large data sets. And I just very quickly went into the search function and typed in health in Africa, and a host of data sets come up, right? So they exist. It's a place where people who are funded by the NIH, for instance, often deposit their data. So we have to collect new data because we have to target a data collection to answer specific questions, but a lot already exists, and at Michigan through the ICPSR.
So on that note, we're nearing the end of our time for this evening's session, but it's been a great discussion. I want to thank each of our 5 speakers for your insights and sharing your experience and the sort of new frontiers that we can be pursuing in data science through the Center for Global Health Equity. I want to note that 2 of our speakers this evening, Bhramar Mukherjee and Akbar Waljee, are the co-faculty leads of what we call a challenge group within the Center for Global Health Equity, one of the first 3 challenge groups that we've launched. We'll be hearing about the other 2 groups on climate and health and on empowering women and communities in subsequent monthly seminars for the Center for Global Health Equity. But this challenge group is an opportunity for faculty from multiple schools and disciplines to come together, and in this case, think about data science opportunities in new ways, both within our own university and importantly with our partners around the world in low and middle income countries. I also want to thank Center for Global Health Equity staff members, Christina Rice and Tanya Piotrowski, for organizing our session and making the webinar work so smoothly. And with that, thank everyone in the audience who has joined us and may be watching the recording of this session later on. It's a great opportunity for us to think about new opportunities to improve global health equity through advances in data science. So thank you again, and hope everyone has a good evening.